My name is Professor Mohamed Bukar. I work with the University of Maiduguri in Nigeria as a lecturer and with the University of Maiduguri Teaching Hospital as an honorary consultant obstetrician and gynecologist. The title of my talk today is Ultrasound as a GPS for the surgeon in Placenta Accreta spectrum. We look at a few case examples after the introduction, and we'll run up with a few take-home messages. The learning objective for this lecture is for us to appreciate how we can use ultrasound scan to guide us in our surgical decision-making in cases of placenta accreta spectrum. All images for this presentation were of patients managed in 2 hospitals in Maiduguri, the capital of Borno State. In the past, ultrasound scan was used mainly to make diagnosis of placenta accreta spectrum. Today, ultrasound scan can be used to guide the surgeon on the type of surgery to offer the patient and what to expect or to anticipate during surgery. Placenta accreta spectrum disorders is a spectrum of conditions characterized by an abnormal adhesion to an invasion of trophoblast tissue through the myometrium uterine serosa. Over the past 40 years, the incidence of placenta accreta spectrum has increased 4-fold, paralleling the increase in incidentization rate. A study from a large Northern population-based study revealed that 70% of cases of placenta accreta spectrum were not detected prenatally, and that the mean blood loss was 4.6 liters, and 44% of the women had hysterectomy. This systematic review and meta-analysis looked at the influence of prenatal diagnosis of abnormally invasive placenta on maternal outcome. And the conclusion was that prenatal diagnosis of abnormally invasive placenta is associated with reduced hemorrhagic mobility compared with cases in which such anomalies are detected at delivery. The value of prenatal diagnosis is not only in reducing the hemorrhagic mobility, because it also prevents unscheduled peripartum hysterectomy, uterine rupture, shock, multi-organ failure, injury to pelvic organs, and many post-operative complications. In addition, it also gives us the opportunity to make the correct diagnosis of placenta accreta spectrum. Based on the prenatal diagnosis, the surgeon can plan what kind of surgery to offer the patient, either conservative or radical. Where facilities exist, we can liaise with the interventional radiologists for internal iliac artery balloon or internal artery embolization. The surgeon can decide beforehand the type of skin incision to make, whether to make the less popular transverse skin incision or the more popular midline skin incision. A study has shown that 93% of women with PAS bleed spontaneously beyond 35 weeks. When we make prenatal diagnosis, this will guide us on when to deliver these women before they start spontaneous bleeding. If the diagnosis was made in a center that is not equipped to handle such cases, we can refer these patients after giving them steroids. ICU team can be prepared, and MTD team can be assembled beforehand. This will reduce both morbidity and mortality associated with placenta accreta spectrum. As I said earlier, today is not just about using ultrasound scan to make a diagnosis of placenta accreta spectrum. No. Today, we use ultrasound scan as a GPS to guide us on what to do and what not to do in case of placenta accreta spectrum. And these are the clairvoyants of surgical difficulties. You have both the grayscale and the Doppler features. The grayscale will give us an idea about the upper limit of the placenta so that we know where to make our incision. If the placenta is deep in the pelvis with posterior extension, it suggests to the surgeon that there is likely to be deep pelvic hemorrhage and injury to the ureter is increased. when there is adequate residual myometrium in the lower uterine segment, then conservative surgical approach is feasible. When there is pelvic wall extension and extension into uterine artery, the chances of heavy bleeding is increased. If there's placenta, I beg your pardon, if there's bladder involvement, the urologist will be part of the team. In terms of Doppler difficulties, everything revolves around increased blood flow, subplacental hypervascularity, uterovesical hypervascularity, bridging vessels, vascularity around the uterus, and intracervical legs. All these are associated with massive bleeding and requirement for massive transfusion. We cannot talk about ultrasound scan as a GPS for placenta accreta spectrum without touching on the options of management. The standard is cesarean hysterectomy. But of course, there are other options. Basically, 4 conservative procedures. One is the one-step conservative surgery, where the invaded area together with the placenta is resected and the uterus is reconstructed as a one-step procedure, provided there is no invasion into the cervix or the perimeter. 2, the triple P procedure, where the placenta is localized preoperatively using transabdominal ultrasound scan, and an incision is made above the placenta, and balloon catheter is placed preoperatively in the internal iliac artery and only inflated after delivery. There's also a modification of the triple P, where instead of the internal iliac balloon, the internal iliac is ligated. The third is the extirpative method, which is forcibly removing the placenta manually to empty the uterus, which is discouraged because it's associated with massive hemorrhage. And lastly, is leaving the placenta in situ, and of course, without giving methotrexate because it's of no value. This multi-center study in 25 French university hospitals looked at the maternal outcome after conservative treatment of placenta accreta. And what was their conclusion? That conservative treatment of placenta accreta can help women avoid hysterectomy and involves a low rate of severe maternal morbidity in centers with adequate equipment and resources. This study, titled Fertility and Pregnancy Outcomes Following Conservative Treatment for Placenta Accreta, looked at the fertility outcome and concluded that successful conservative treatment for placenta accreta does not appear to compromise women's subsequent fertility or obstetric outcome, but that the risk of recurrence of placenta accreta during future deliveries is high. The first GPS. We know that as the number of cesarean sections increases, so will the number of placenta accreta spectrum increase. So there's increasing risk of adhesions in patients with placenta accreta spectrum. So one of the GPS is to determine whether the uterus is adhered to the anterior abdominal wall or not by doing the sliding sign. This is the myometrium. This is the anterior abdominal wall. So you can see the uterus sliding freely under the peritoneum, suggesting that there are no adhesions. So you are guided by the GPS that you can comfortably make your incision on the fundus without encountering much problem as far as adhesions are concerned. One of the greatest challenges intraoperatively is hemorrhage. And one of the easiest way to temporarily control bleeding is to compress the aorta. That can be done manually. But where you have peri-aorta clamp, that's fine. But if you don't have the clamp or any other of the aortic clamps, you can manually compress the aorta and bleeding will stop temporarily. The first case was a 39-year-old multipara with 3 previous years at 22 weeks of gestation with dichorionic diamnitin pregnancy. She has 14 at 9 weeks of gestation. So if you had seen her at 9 weeks, probably would have picked whether it was low implantation, whether it was implantation into a niche, or on the scar, or have counseled her appropriately. The placenta of the upper twin was fundal, while that of the lower twin was previa. She had cesarean hysterectomy at 31 weeks of gestation due to preterm contractions, baby weight 1.6 kg. At 22 weeks, look at this yellow line. Behind the yellow line, you can see extension of the placenta. So there's posterior extension of the placenta. This suggests to us that there's increased risk of deep pelvic hemorrhage and risk of ureteric injury is high. Myometrium, as early as 22 weeks, there is absence of myometrium. As early as 22 weeks, we can see subplacental hypervascularity. This initial bulge suggests that it may end up as placenta increta or Accreta. Reassuringly, there are no intracervical legs, suggesting that we can comfortably do a subtotal hysterectomy and leave the cervix behind without fear of bleeding from the cervix. At 30 weeks, again, she came up with bleeding per vagina. Here you can see the lateral extension. Look at the lacunae up to 6, grade 6, grade 3 lacunae. Still absence of myometrium. Now, this is a case, a normal case, transverse section of the cervix depicting the uterine artery. So if you have a case of placenta Accreta spectrum with lateral extension, there is possibility that it may also involve the uterine artery. At 30 weeks again, you can see these multiple bridging vessels. This suggests that in an attempt to make a bladder flap, you're likely to encounter torrential bleeding. Look at the lacunae, fill up with vessels. Subplacental hypervascularity, again, absence of myometrium. In the upper segment of the broad ligament, you can see these tortuous blood vessels. And at laparotomy, this is the tortuous blood vessel seen on ultrasound scan. Remember the lateral extension? Look at the lateral extension and the bulge here. And look at these blood vessels. So this probably contraindicates surgical staging because the ultrasound scan has already guided us as a GPS to avoid surgical staging because of this engorged blood vessels and the lateral extension. These are the bridging vessels on power Doppler. These are the bridging vessels at cesarean hysterectomy. Remember the posterior extension? This was after the delivery of the twins. Look at the posterior aspect of the uterus because of the posterior extension. Again, this is the specimen after laparotomy. You can see the lateral bulge here. And these are specimens at laparotomy. Histopathology confirmed that it was placenta increta, not placenta Accreta, as was diagnosed by ultrasound scan. Case 2 was a 30-year-old HIV positive woman with placenta previa and bilateral placenta. She had cesarean delivery. At 30 weeks, not this subplacental hypervascularity. Note that there is normal myometrium here, suggesting that if there's a need to do a conservative surgery, that can be successfully done. Here, look at the lacunae here, grade 2 lacunae, the bilateral placenta, normal myometrium here, but around here you can see there is focal increta, and the focal increta is around the area where you have this concentration of lacunae. At surgery, you can see this focal increta. Ultrasound scan as a GPS for the surgeon. Case 3, a 30-year-old gram multipara, 35 weeks with APH and sausage lobe. Placenta was cut through to deliver a baby, estimated blood loss 1.5 liters. At 35 weeks, you can see normal myometrium here, which is reassuring. Look at the connection between the two lobes of the placenta. So you'll be guided to make our incision here and avoid the placenta. Note the subplacental hypervascularity, absence of intracervical legs. On power Doppler, look at the uterovesical hypervascularity appearing like the real sign, although not typical of the real sign. And you can see absence of myometrium here and thin myometrium somewhere here, no intracervical legs. Transvaginal ultrasound scan, you can see the lower segment riddled with blood vessels. Look at that at laparotomy, and this was the power Doppler of the same case. Case 4 was a 39-year-old gram multipara who presented with bleeding per vagina. Following 2 previous bleeds, she developed severe hemorrhage at cesarean section and had uterine artery ligation because of overswinging the bleeding point was not successful. You can see the symmetric placenta previa. You can see the subplacental vascularity that has extended into the cervical stroma, giving this appearance of intracervical legs. This was an incidental finding of placenta per Accreta accident section following previous myomectomy. Can placenta Accreta spectrum be prevented? Yes, it can. Over the last 40 years, the incidence of placenta Accreta spectrum has increased, largely because of increase in cesarean section rate. So by reducing primary cesarean section rate, we can reduce the rate of placenta Accreta spectrum. When we observe good surgical techniques, when we close the uterus in double layer rather than single layer that will leave defects, we reduce the rate of placenta Accreta spectrum. Let's respect the endometrium and avoid overzealous curettage. As much as possible, if it is feasible, let us avoid breaching the endometrium during myomectomy. When patients present with postpartum endometritis, they should be treated appropriately. It's important to make early diagnosis of cesarean scar pregnancy because cesarean scar pregnancy is a precursor of placenta Accreta spectrum. Let's look at a few pitfalls. These dark areas you see here interposed with this echogenic area are blood vessels, as you can see on this power Doppler. These are the same vessels that you see here subserosally. So, bridging vessels are not features of placenta per Accreta, as you can see. Here was a patient with placenta previa, not the blood vessels here, not the uterine serosa here, the bladder wall here. On color Doppler, you can see bridging vessels. And as cesarean section, look at the bridging vessels. So bridging vessels are not features of placenta per Accreta. This is normal placenta blood flow, not lacunae blood flow. This is one of the importance of placenta mapping. If you do not map the placenta and you make your incision across this, you can imagine the torrential hemorrhage that may follow. So, our take-home message is that early ultrasound scan at 5 to 7 weeks is important in women who are at risk. Because if the ultrasound scan is done beyond 7 to 8 weeks, it may not pick lower uterine segment implantation into a niche or on the scar because the placenta will grow and occupy the uterine cavity. It is important to screen women who are at risk of placenta Accreta spectrum during the routine anomaly scan where that is done. We remember the systematic review and meta-analysis shows that prenatal diagnosis of PASS significantly reduces morbidity and mortality because it also serves as a GPS for the surgeon. Especially in cases of Accreta, high index of suspicion is needed because the other features of placenta Accreta system may not be obvious. There may be no lacunae, myomectomy may be normal. Let's always remember pitfalls associated with diagnosis of placenta Accreta spectrum. Thank you very much for listening.
Abin da za ka shirya da abin da za ka yi shi hannu ko kuɗinki a'a zuwa rubutu a wajen tica ka koya. Oh, tica yana da